Hi guys, good evening to everybody. Excellent. Karthik, would you be able to make the screen of myself a little lesser? Is it feasible? Okay, fine. Okay. Am I audible, guys? Okay, thank you. So today I have chosen a topic which is a little confusing, but in hepatology unit, one of the quite common diagnoses that we come across. So the topic is management of ACLF, where ACLF stands for acute on chronic liver failure. Now, first, let's see what is this liver failure. Now, liver failure is where we talk about one single organ, that is, liver being primarily the organ which has failed. Now, this in clinical scenario can occur in three different stages. One, when the patient had a completely normal liver and then gets an acute insult and leading on to liver failure, which occurs in the scenario what we call as ALF. We are not discussing about that right now. Second, this could also be a part of deterioration in a patient with end stage liver disease. So, both are quite distinct from what we will be discussing today, that is ACLF, which stands for acute on chronic liver failure. Now, I will be coming to few of the definitions of ACLF, but we should be knowing that ALF and a decompensation in ESLD is different. Now, sometimes we come across some words like acute decompensation. Now, what is this acute decompensation? Now, acute decompensation is defined as an acute deterioration in the liver function in a cirrhotic patient within 3 months, not initially presenting as liver failure. So, a cirrhotic patient who comes without failure with some decompensated features like variceal bleed, ascites, hepatic encephalopathy, or renal dysfunction. Now, this is defined as acute decompensation. So, this word is different from ACLF. So, these are some of the things that we should know. Now, coming to what, let me be a little more clear about acute decompensation, which we should know quite well. It is an acute deterioration of the liver function in a patient with prior decompensation or persistent decompensation with or without involvement of other extrahepatic organs. Okay, so this is a condition where a patient with prior decompensation or persistent decompensation has an acute deterioration with could be liver involved only or with extrahepatic organ involvement. Okay, now this the time here an acute decompensation often occurs in response to a persistent or progresses rapidly with a very high 3 month mortality. Okay, so here we should know that there is a precipitant for an acute decompensation and the 3 month mortality is quite high. In ACLF, the terminology we use is a high 28-day mortality. Okay, so here there is little better prognosis. Now, the presentation can be an acute development of large ascites or hepatic encaph or a variceal bleed or a bacterial infection, HRS, or combination of this. So, acute decompensation involves all of these basic decompensations that we see in a known cirrhotic patient. So this should not be confused with what is today's topic, that is ACLF. Now ACLF is a distinct syndrome of liver failure. Okay, first thing is it's a liver failure in a patient with chronic liver disease. Now again, I'm not mentioning a cirrhotic or non-cirrhotic. It could be either of it, but patient should have a chronic liver disease where the patient presents with jaundice and coagulopathy and ascites and or hepatic encephalopathy developing following an acute hepatic insult and is associated with a very high with a high 28-day mortality. So let's split up the definition. I'll go into specific definitions a little later. So this is specifically where there is liver failure in a patient with chronic liver disease which presents as with jaundice and coagulopathy and complicates as ascites or hepatic encaph and has a high 28-day mortality. Now, as I have already told, we should differentiate this fact from ALF and an acute decompensation in an end-stage liver disease. Now, here there are some distinct pathogenesis and that is seen in the patient. There is an initial systemic inflammatory response syndrome because of cytokine storm in relation to the acute insult and or subsequent development of sepsis due to immune paralysis, which in turn even leads to extrahepatic liver organ failure. So here presence of SIRS, which later can go on to sepsis and organ dysfunctions, other organ failure is quite important. So initially there is presentation as liver failure characterized by significant SIRS, may be complicated by sepsis and immune paralysis in turn leads to other organ failure. So this, if briefly we remember as the natural history of ACLF, we would be quite clearer. Now, these cascades of events progress through a golden window period of around 7 days and subsequently to which majority of the patient develop complications which like sepsis or extrahepatic organ failure. So this initial phase when we pick up at the early days, we should be able to be like prevent sepsis, support the organ and manage the organ failures. And also at this golden window period, we should be able to refer for a in the transplant setting. Now this at this stage, a lot of multidisciplinary approach is important for a significant transplant-free survival. Now, coming to overall management per se, there are totally 5 principles, each of which I'll be coming in detail. One, basic supportive therapy, then specific therapy based on etiologies, bridging therapy in case the patient has been waitlisted. We need to give some therapy so that we can delay the prognosis and get the patient to a definitive therapy, which is liver transplant. Of late, there are more cases where experimental therapies, cell-based therapies, or regenerative therapies are being employed at a few places with mixed results. So let me now come to what is ACLF. What are the current definitions? Now, one of the first definitions for ACLF was by Asia Pacific Association for Study of Liver Disease, that is APASL. So 2009, I guess, this definition came up, and they have a research consortium which is AARC. So based on that, the definition is the one which we commonly use in this particular setting. One more definition is the European EASL definition, where CLIF SOFA score and CLIF OS scores are used. And these are the 2 definitions which we should commonly know, of which most important one is APASL definitions. Okay, because the concept of golden window was emphasized, and the concept of, more importantly, liver failure rather than extrahepatic organ failure was concentrated more in this particular scenario. Okay, so now coming to the Apasal definition. Now coming to apasal definition, just 2 points we have to know about this. Now here, according to apasal, the ACLF is defined as an acute hepatic insult which manifests as jaundice, that is bilirubin more than 5, and coagulopathy, that is INR more than 1.5. That means they present with jaundice and coagulopathy. Jaundice more than 5 and coagulopathy more than 1.5, complicated within a span of 4 weeks by clinical ascites with or without encephalopathy. And we should know that previously this patient may have an undiagnosed chronic liver disease. Now, chronic liver disease may or may not have cirrhosis. Okay, so that's more important. So, in a chronic liver disease, now what is the definition of chronic liver disease? Chronic liver disease is defined as a diffuse liver disorder which can be because of any etiology which has a high propensity of going towards cirrhosis and its complications. So it may need not have cirrhosis per se according to its definition. Okay, so that's the thing. So it is later that they added one more definition, which says that it includes a high 28-day mortality. Okay, so a high 28-day mortality was added to the original definition later. So the definition includes jaundice more than 5 with cirrhosis with coagulopathy more than 1.5 complicated within 4 weeks by ascites and or encephalopathy in a known case of chronic liver disease which can be with or without cirrhosis with a high 28-day mortality. So this is the definition. Okay, the high 28-day mortality. I would not want to go into more definitions. It is, if you are clear with this definition, that is more than enough. Okay, so just to make it more picturesque, this I have taken from the apasal definition. So first we should be able to define the liver failure, which is jaundice and coagulopathy, which within 4 weeks complicates as ascites or hepatic encephalopathy in a case of chronic liver disease. Okay, in this case, there is importance of trying to find out what the probable acute insult is. It could be ethanol, it could be hepatitis B reactivation, it could be viral hepatitis, there could be autoimmune hepatitis, it could be DILI, it could be Wilson's flare, or it could be unknown. So our investigation, when we see and we want to evaluate for the acute event, we should be able to define, and our investigations at initial stage for etiology should be based on finding out what the acute insult is. Next, coming to the other definition, that is the European definition that was based on a canonic study. Here, the acute on chronic liver failure in cirrhosis is defined as an acute deterioration of a pre-existing chronic liver disease, usually related to a precipitating event, and is associated with a high mortality at 12 weeks due to multi-organ failure. So here, the emphasis is on multi-organ failure, multi-system organ failure, which in here, so extrahepatic organ failures have been given more importance in this definition. It is later that the duration was reduced to 4 weeks. So currently even here the definition is around 4 weeks. I would say that just for simplicity, if you know the concept of ACLF and you know at least a single definition, that is apasal definition, and work up the patient accordingly, it would be easier. Okay. So far I have tried to help you identify what is ACLF, how is it different from ALF and ESLD, and first we should be clear with defining ACLF and picking up the patient. So first, in a management strategy, we should be able to pick up these particular patients, and then comes how do you manage the patient, which each by each I'll be coming in due course. One, nutrition and supportive care plays a major role. Then etiology specific treatment for few conditions is important, especially to attack the acute insult. Then comes prevention and management of organ failure, prevention and management of its complications. Then we should have, I'll be discussing about few dynamic prognostic models. Then when to actually think about transplant and when to make that kind of decisions. And then we will see what are the non-transplant options in case if transplant is not feasible, and management after recovery from attack of ACLF. Okay. So these are some of the things that we should be looking at in this particular case. Okay. So coming to nutrition and general care. Now nutrition and general care, I would say that carbohydrate, because liver is affected, the glycogenesis, the glucose storage is less. Carbohydrate predominant diet should be preferred. A late evening carbohydrate rich snack is preferred. Protein should be given up to 1.5 gram of protein per kg per day, and we should make sure that calories are at least 39 kilocalories per kg per day. Now, it may be beneficial to choose a nutrient diet, nutrient dense formulas in these patients. Usually, it will have 1 cal, but in these patients, we should be able to give 1.5 to 2 cals per ml. Now, considering the consideration of soya-based lipid emulsions may help reduce the inflammation, especially with the onset of intestinal IBS. Sometimes, if we are not able to feed orally that target, we might even go on to supplements and enteral tube feeding. Okay, so this is with respect to nutrition, which is least considered in many settings. Next topic that I wanted to tell you was identification of injury and specific therapies. Suppose first thing is an HBV reactivation. Now, in this kind of patients, reduction of HBV DNA less than 2 logs, that is, if the initial DNA and after treatment the DNA reduces by at least 2 zeros from the end, then with tenofovir has shown to improve the transplant-free survival from 17 to 57% in RCT. What I want to say is, if it is HBV reactivation, put the patient on tenofovir, and the effect is so much that if there is 2 log reduction in DNA level after 2 weeks of starting tenofovir, many times we might even prevent a need for transplant. So that is one point I wanted to emphasize. Now, there are some specific features which helps us decide which kind of patient will require liver transplant, but I think that won't be required at this point of time now. Now coming to next etiology, alcoholic hepatitis. Here again, nutrition, psychosocial rehabilitation, anti-craving drugs like baclofen and corticosteroids play a major role. Now, response to corticosteroids is seen in 60% of patients with better short-term survival, but usually 6-month mortality rates are not quite good. Now, the steroid response, the question they may ask you is, you use Lilly model to find out how good is the steroid response at first week to really decide whether we'll have to consider for an liver transplant. So the questions could be based on this. Of late, initially pentoxifylline was used in this condition, but nowadays the studies are telling that there's not much use with pentoxifylline. Okay, that is one more data I wanted to tell you. So steroids are the gold standard in this setting. Of course, you should not have some of the contraindications for steroids in these patients like sepsis or AKA or GI bleed. So what apart from steroids are seen in these, are used in these patients? Now, GCSF has been tried and is an emerging concept. Then interleukin 2 receptors also are under trial. Fecal microbiota transplantation or IMT is being tried. Otherwise, we have studies on pentoxifylline, S-adenosylmethionine, and anti-TNF alpha inhibitors are being tried. Basiliximab and TLR4 antagonists and IL-1 receptor antagonists are also a lot of consideration has been done, but none of them have been so far proven to be the gold standard. So these are all under trial. But however, majority, if you see, we are targeting the SIRS, that is the cytokine storm that is occurring in these patients. Okay, so that's one thing. So now let me go to other etiology, autoimmune. Again here, a short trial of corticosteroids has been shown to be useful, and there are some scores to say how good they are and can also prevent liver transplant in some setting. The recommendation for second line immunosuppressants like tacrolimus or mycophenolate is still inconclusive. So just like the other study, even here this it does autoimmune hepatitis or like in alcoholic hepatitis, steroids play a good role in these two etiologies. Now that's what we should be knowing in this condition. Okay. Next, I would like to discuss with you about DILI. Now, among the drugs, the most common in India is anti-tubercular drug, followed by a complementary alternative medication, which is most commonly implicated. Okay. Now, this is in contrast with the Western cohort where anti-epileptic drugs are implicated in RTP. Now, the baseline MELD score and hepatic encephalopathy were strong predictors of mortality and for early consideration of transplant. So, DILI is again etiology specific treatment can be done and few settings. So, next comes, so far we are seeing two implications in the management. Now, next coming to organ failure support and management of complications. Now, there are various scores being used, but of late the SOFA is commonly being used, and we have other studies like CLIF SOFA and then APASL ARC score being done of late to know what is the degree of involvement of liver and other organs. Now, this is a brief picture from APASL guidelines which I have taken. Now, the natural history says initially there is no SIRS, they may go on to SIRS, then there is immune paralysis which causes increased permeability of the gut and causes gut translocation leading to sepsis and later can go on to shock. So, this is the progression. Okay. Now, according to APASL, we'll be able to pick the patient in a golden window period rather than EASL, which tries to pick up the patient once the extrahepatic organ failure sets in. So, it is in this golden period, this 1 week time, that we get to decide in what direction the patient goes, what are the preventive measures that we can take. Next comes managing individual complications that occurs in these patients. A few of them are most important being hepatic encephalopathy. Now, arterial ammonia. Remember, arterial ammonia is a good surrogate marker to know the severity of hepatic encephalopathy. And ammonia-focused therapy like lactulose and rifaximin are known to reduce the likelihood of HE grade. Okay. Now, patients with HE need ICU monitoring, mechanical ventilation, especially for advanced airway protection, targeted ammonia reduction, management of precipitating events play the cornerstone in the treatment. Now, advanced grade of HE, new onset HE warrants an early liver transplant. Okay. Next comes acute kidney injury. How would you treat an acute kidney injury in this setting? First thing is you need to stop some precipitating factors. It can be some drugs, diuretics, or it could be other factors like bile pigment nephropathy or an acute tubular necrosis or sepsis itself presenting as raised creatinine. So we should be very careful and try to discontinue NSAIDs, nephrotoxic drugs, diuretics. Antibiotics has been proven to help in when there is suspicion of a proven infection, and we should be able to correct hypovolemia, and adequate use of a combination of albumin and terlipressin has been proven quite effective in this particular setting. Now, the patient may go on to develop other indications for renal replacement therapy. So, if terlipressin and albumin, if there is no adequate improvement, patient may go on to dialysis. Now, these patients are quite sicker group. So, if they ask the question, what modality are you going to use in hemodialysis, CVVHD is the treatment of choice. But this is even better than SLED because of the hemodynamics that is there in these patients, which is there is significant hypotension and other things. So, a continuous venous hemodialysis is the preferred modality of RRT in case of a renal failure in this particular setting. Next comes sepsis-induced hypotension and shock. Now, prophylactic antibiotics is recommended at an early stage. Now, the sepsis it has been proven that albumin, by some studies, that can play a good role in decreasing the circulating PGE2 levels, which can, increase the alpha TNF alpha levels and may help in decreasing the monocyte energy and increase the responsiveness of our immune system to attack the sepsis. So what we should know in this condition is in ACLF there is cytokine storm, but there are also some cytokines which are present which cause kind of immune paralysis. That is, the responsiveness of the macrophages or the monocytes are blunted. So that gets unmasked. That is actually caused by PGE2 levels. So albumin reduces PGE2 levels and increases the responsiveness. Okay. Apart from that, any other sepsis, how we treat IV fluids has to be given. And in this specific condition, vasopressors play a major role, and vasopressor of importance is norepinephrine, just like any other sepsis. But in this particular setting, what else is important is the role of terlipressin. Now, the use of terlipressin is associated with added advantage for reducing the risk of variceal bleed, nosocomial SBP, improved microcirculation in septic shock, and possible better resolution of HRS and sepsis-associated acute kidney injury. So these are the things which play a major role in these patients. Next, coming to liver respiratory failure management. Now, these patients could have various other conditions like pneumonia, ARDS, fluid overload condition, or advanced encephalopathy, and all this may require airway protection. Initial attempt for, however, non-invasive ventilation is recommended, except in those with like non-cooperative patient or those with significant high-grade HB. Now, if there is acute variceal bleed, use of non-specific beta blockers is in a relatively sick ACLF patient has showed a reduced incidence of sepsis, AKI, hypotension with short-term survival benefit according to few studies. So you might be wondering beta blockers in a patient with the hypotension, but actually in this particular setting, it has shown according to few studies some improvement. We should be able to identify high-risk groups, those like with large high-risk varices, like presence of red color sign, and others like persistent liver failure or early primary prophylaxis with NSSP can also be considered. Okay. Now, endoscopic variceal ligation is debatable and needs decision considering the coagulopathy and the risk of post-tibial bleeds that could occur in these patients, especially when it comes to primary prophylaxis. Secondary prophylaxis is just like any other case of cirrhosis, we should be able to treat it that way. But primary prophylaxis with EVL, it's little dicey. Okay. Now, there are disease severity assessments and various prognostic models like SOFA, Apache 2, Cliff SOFA, MELD, and MELD sodium. And easel Cliff is used, but however, it is cumbersome in general practice. Considering all this, recently there was an Indian study which came up with SOFC, that is simple organ failure count, to say that based on number of organ failure, whether it is 1, 2, 3 or more, you can classify the patients as no ACLF or 1, 2, 3 ACLF. There was significant correlation with a canonic grading system. Okay, there the definition for organ failure, which was very similar to canonic study, was true. That is, liver failure was defined by bilirubin more than 12. Coagulopathy was defined as platelets less than 20,000 or INR more than 2.5. Renal failure was defined by need for RRT or a creat level more than 2. Cerebral failure was defined as grade 3 or 4 hepatic encephalopathy according to West Evans. Circulatory failure was defined as vasopressor requirement. Respiratory failure was defined as PF ratio less than 200 or SpO2 by FiO2 ratio less than 240. However, with respect to organ failures, coagulation failure was removed, and rest of them, according to SOFC criteria, can be used. So, SOFC, that is organ failure count, single organ failure count. The counts can also be used as a significant prognostic marker in ACLF patient. Now, just a small note, whether liver biopsy plays a role in prognosticating, it may play a small role. I would not want to go into big details because it is generally not encouraged because of the severe coagulopathy and presence of coexisting ascites in these patients. However, if they ask you still you want to do it, then transjugular path has been shown to be safe. This helps us stage the fibrosis, necroinflammation, and also in etiology, it's like a drug-induced or Wilson's or autoimmune hepatitis, histology can play a role. Next, I'll come on to APASL, that is ARC score, which is with respect to Asia-specific study. So here they emphasized more on liver failure parameters along with creatinine. That is bilirubin, hepatic encephalopathy grade INR, and lactates. Okay, and creatinine. So this lactate, apart from MELD score, this has some extra thing that is lactate. This can again be tested in your questions. And here, the scoring system ultimately classifies the patient very similar to CTP scoring. Like 5, 7 is 1, 8 to 10 is grade 2, and this is grade 3. Okay, I'll come to implications of this simple scoring system later with respect to decision management or deciding when not to transplant, when to transplant a patient, or when to just give supportive management to the patient and try. Okay, so I would like to then just ultimately end the topic by just briefly talking about in an ACLF patient how to manage. Now, in an ACLF patient, first see that acute insult. What is acute insult? Okay, you treat the acute insult like ethanol or tenofovir or steroids or stop the drugs or Wilson's with a probable role of chelation therapy. So you see what is probably the acute event, and then you measure the liver failure symptoms. Now the liver failure can be graded as the various scores are there, but what we commonly use at this point of time everywhere is the MELD score. Now, apart from MELD score, we can also give some other topics like we can use other study scorings like ARC scoring, AARC. Okay. Now, based on MELD score, if the score is more than 30, that means the liver failure is more. So, apart from treating the acute insult, you should be able to give supporting care and see at day 7 whether there's any improvement with the patient. If there is improvement, then we can observe the patient. If there is no improvement or there is new organ failure, then we should be considering liver transplant. Okay. If the score is less than 30, apart from acute management, we manage the patient and observe for 7 days. If there is new onset organ failure, we should be able to transplant. Okay, refer the patient for transplant. If the score is high, the liver score is high, MELD score is more than 30, then you see how sick the patient is. If there are 2 and more organ failure, you give supportive care. If there is no improvement, only supportive care, patient is not even transplant fit. If the patient shows some recovery with respect to organ failure, then you consider for liver transplant. Suppose if the patient has severe liver failure, that is MELD score more than 30 with no organ failure or single organ failure, now that is the patient we should ideally consider for liver transplant. Okay, so this is the classification with how to decide based on health score. Now the same, I would just like to have taken one picture from the APASL based on ARC scoring. Now according to ARC scoring, again, there the score we use is it more than 11 or less than 10. So less than 10, again it's a MELD score, less than 30 what you do. And if the MELD score, if the ARC score is more than 11, the patient is obviously having a more liver failure. So you would look for whether a single organ failure or multiple organ failure and base your decision. So ultimately what I would want to tell you is, if the patient has 2 organ failures or more, you give treatment, supportive treatment for at least 1 week and see for recovery. If the recovery is there, a patient is downgraded to no organ failure or one organ failure, that is when you consider liver transplant. Okay. So next, coming to bridging therapy. Now, bridging therapy is a therapy which is given to bridge a patient for organ transplant. That means for liver transplant, patient may initially be non-eligible, or the patient is listed and you are waiting, and that is when you would want to give some other therapy and see whether it helps. Now, you would classify bridging therapy as an artificial liver support system that includes plasmapheresis, liver dialysis, and bioartificial liver. Now, these are the three modalities. The key concept is these methods, one, they remove the harmful toxins, they support the liver for spontaneous rejection, and they also reduce ongoing inflammatory injury. So, a brief word on plasmapheresis. Of late, this is being also called a liver dialysis, but this is not liver dialysis. Plasmapheresis is where therapeutic plasma exchange is being done in order to remove the toxins and add some supplements which will help in buying time, and there are also studies which say that it also improves the uh, survival of some patients, and some patients can even come out of liver transplant and have a good transplant-free survival. Now, liver dialysis includes some methodologies like MARS and FPSA, that is fractionated plasma separation and absorption. These studies are more, may help or may not help. These are basically to buy time to put the patient to liver transplant. Now, bioartificial liver support system, there are usually commonly used ones are three types. One is AMC BAL bioreactor, HEPA-assist device which has a porcine hepatocytes, an extracorporeal liver assist device, that is ELAD, where human hepatoblastoma cells are used as kind of combined with some hemodialysis filter. So these are the three bioartificial liver support devices. Now, this should not be confused with hepatocyte transplantation. I'll be coming to that also. Now, there are few emerging and experimental therapies. These include cellular therapies and non-cellular therapies. Cellular therapies are hepatocyte transplantation and stem cell transplantation. Non-cellular therapies are like studies where we give growth hormone like GCSF, and there are more stem cells which goes and migrates to the liver and helps in regeneration. Okay, so these are all studies which are basically experimental. So you should be able to classify what is definitive therapy, that is liver transplant, what is a bridging therapy, what is experimental therapy in these particular conditions. Hope you guys understood. I know it's a tough topic, but just a small subset of topic that we should know. Thank you. Have a nice day. Let me see if there are any questions in the chat box. There is some lag between how I'm talking and what's reaching you guys. Okay, so far no questions, no phone calls. Okay. Thank you guys. If there's any questions, please put up in the WhatsApp group. We'll be able to chat later. Thank you.